I'm going to wait a couple minutes to let everyone join. All right, everyone, we will get started. My name is Hiba. I am an intern with the Illinois Department of Public Health. So thank you everyone for joining the session today. I'm just going to be introducing today's speaker for our session. We have Dr. Suda. Dr. Suda is currently a professor of medicine at the University of Pittsburgh School of Medicine, associate director of the Center of Pharmaceutical Policy and Prescribing, and a research health scientist and associate director of clinical therapeutics at the VA Center.
So before I begin, I wanted to state I have no conflicts of interest, but I am receiving funding to support my research program, all from federal sources. And I particularly want to highlight an R01 from AHRQ and a VA Merit Award from HSR&D, which supported some of the research that I'll present to you today. And because I also do research at the VA, I'm required to tell you that the opinions expressed today are those of my own and do not represent those of the VA or the US government. So I want to acknowledge everyone for your interest in the dental track. It's a very exciting new area, and I'm so pleased to see so many dentists registered for the conference today. So there will be 3 talks this afternoon. I'm the first presenter, and I will focus on the data, what we know about antibiotic prescribing by dentists, primarily with a focus on US data. The next talk at 2:35 will focus on what is the evidence, particularly doing an in-depth review of the guidelines, as well as describing antibiotic-associated adverse events that are attributed to antibiotic prescription by dentists. And then the last talk this afternoon at 3:45 will provide a very nice example of what's been done locally at UIC on implementing antimicrobial stewardship in dentistry. So my objectives are to describe patterns of antibiotic prescribing by dentists, as well as summarize data on unnecessary and inappropriate antibiotic prescribing by dentists in the US. So I am going to describe multiple data sets today, and I'm going to go back and forth between these data sets. The first data set that I'll describe some results from is Medicare Part D prescription data, which is comprised primarily of persons over the age of 65, but not exclusively, who are enrolled in the Part D benefit of Medicare. Then I'll describe IQVIA population-level prescription data, which has over 92% of all prescriptions dispensed in the United States. And these data were also referenced this morning in some presentations by the CDC. And then we'll describe some claims data from MarketScan, which has persons with commercial or Medicare insurance and who also have commercial dental insurance. And then I'll provide some insights from our data in the VA using the corporate data warehouse. And as many of you probably know, the VA is the largest healthcare provider in the US and is also the largest oral healthcare provider. Now, while 8 to 9 million veterans receive care annually in the VA, only about 500,000 veterans are eligible for dental benefits. Also, I'm going to share some unpublished results, so I ask that you not share these results at this time. Some of the results are in press, so they will be released shortly. And if you want to drop your name in the chat, I'm happy to share the results that you're interested in when they're either presented in a public forum or when they're published. So because we have some audience members that are probably new to antibiotics, to antibiotic stewardship, I want to make sure we're all on the same page and understand that antibiotics are not safe drugs. They are life-saving drugs, but they are the leading factor in the emergence of bacterial resistance and the development of C. difficile infection. And the majority of bacterial resistance and half of C. diff infection now occur in outpatients in the community. We are seeing some success in decreasing CDI in acute care settings, as well as some resistant organisms. But unfortunately, overall, resistant infections are increasing. And This is really becoming a public health threat because there are few antibiotics to treat multi-drug resistant infections, and with limited drug development, this is unlikely to change. Antibiotics also cause serious adverse drug events, and these adverse drug events are common reasons for visits to the emergency department, especially in children. Now, some of my work involves qualitative interviews with dentists, as well as looking at the past literature. There are some commonly held myths about the impact of antibiotics for indications, for oral health indications. First, that dentists do not contribute to resistance or CDI, and that's simply not true. But the thought behind this is that dentists primarily prescribe narrow spectrum antibiotics and for what is perceived to be a short duration. But I'll share with you in a few minutes that antibiotics prescribed by dentists have the same day supply as those antibiotics prescribed by medical clinicians. In fact, dentist prescribing also leads to C. difficile infection, and there's a lot of data supported by that. In addition, this was quantified in a systematic review led by the speaker this morning, Malavika Tampi, where she quantified the number of dental antibiotics that likely led to community-associated C. difficile infection. The other myth is that antibiotics improve oral pain and swelling. Again, antibiotics, there's been systematic reviews and meta-analyses done which have shown that patients' pain is not improved on whether or not they take an antibiotic. In addition, patients taking antibiotics does not lead to opioid sparing or NSAID sparing, meaning that patients do not take fewer opioids or NSAIDs if they take an antibiotic. So to set the stage to talk specifically about dental antibiotic prescribing, first I'm going to present some data on national antibiotic prescribing. And if you've been a regular attendee of the Illinois Antimicrobial Stewardship Forum, some of these data have been presented to you in the past. So we found that the majority of antibiotic use is in outpatients in the community. But up until the last 7 or so years, little attention was being paid to improving antibiotic use in outpatient healthcare settings. And we conservatively estimate that 60% of antibiotic consumption actually occurs in outpatients in the community. And the community is defined as outpatient healthcare settings, such as your clinics and prescriptions dispensed from retail pharmacies. Since the majority of antibiotic consumption occurs in the community, let's talk about who are actually prescribing these antibiotics. In the United States, physician clinicians prescribe the majority of antibiotics, and family medicine practitioners are the top physician group. Advanced practice providers, meaning nurse practitioners and physician's assistants, now prescribe 25% of all antibiotics in the United States. And dentists prescribe about 10% of antibiotics, but little is known about how or why dentists prescribe antibiotics. Every year in the United States, there's about 250 million dispensed prescriptions for oral antibiotics. And this translates to a population-based rate of 760 oral antibiotic prescriptions per 1,000 population. Said another way, 4 out of every 5 U.S. persons receives an antibiotic annually. We also see significant geographic variation. In the map in this slide, the darker red states indicate higher population-based antibiotic prescribing rates, and the cream color states indicate lower prescribing rates. And what we see year after year is that the highest prescribing rates are seen in the southern United States, with the West having the lowest prescribing rates. We are seeing some success in decreasing outpatient antibiotic prescribing, which has decreased by 5% over about 6 years. There was also decreases in broad spectrum prescribing primarily driven by decreases in macrolides and quinolones. However, there were differences when the results were stratified by age group. There was a 13% decrease in antibiotic prescribing for pediatrics, children and adolescents, but there was a 2% increase in antibiotic prescribing to adults. This indicates that the national decreases that we are seeing are primarily driven by decreases in antibiotic prescribing to children and adolescents. So looking at these data, where are antibiotics increasing? This is in persons aged 40 years and above. For clindamycin, which the class that clindamycin is in are called the lincosamides, in both children and adults, and antibiotics prescribed by advanced practice providers and by dentists. So let's now talk specifically about dentist prescribing of antibiotics and compare how dentists prescribe antibiotics when compared to medical clinicians. So I mentioned earlier that dentists prescribe 1 out of every 10 antibiotics in the US and are the top specialty prescriber of antibiotics. And this is an important issue to talk about to dentists because antibiotics are the primary medications that are prescribed by dentists. We used Medicare Part D data and found that almost 60% of all prescriptions prescribed by dentists were antibiotics. I know some of you may be thinking, well, this is a Medicare Part D population and this is an older population. And while that's true, we have access to several different data sources, and all of the data points in the direction of about 55 to 60% of all medications prescribed by dentists are antibiotics, and about 15 to 20% of all medications prescribed by dentists are for opioids. So there's also some geographic discordance when we compare antibiotic prescribing rates for dentists when compared to national data. So the national data that I have here is on the right. This is data from the CDC of all prescribers. And again, the darker red states indicate the highest prescribing rates. And what we see is that the highest prescribing rate was in the South. But when we look at population-based rates of prescribing for dentists, the lowest prescribing rate was actually in the South, and the highest was in the West. And this is exactly opposite what we see when we look at the data for all prescribers. So why does this matter? Because public health focuses some stewardship efforts based on areas with high antibiotic prescribing. Thus, these efforts may not be reaching areas with the highest prescribing dentists. We've also looked at the county level and the percent change in dental antibiotic prescribing rates. So the map in this slide is showing the percent change in antibiotic prescribing rates over 6 years. The darker red counties indicate a greater than or equal to 25% increase, and the blue counties indicate a decrease. We found that 20% of counties had a greater than 10% decrease over the 6-year period. But we also observed that almost half of all counties in the United States had a greater than 10% increase in antibiotic prescribing. In this analysis, we also included opioid prescribing, and I know some of you are also interested in opioids. So what we found in this analysis, which is rather interesting, is that those counties with the highest high opioid prescribing rates were predictive of high antibiotic prescribing rates. So there seems to be some association between these two medication classes. But I would love to describe opioids more, but that's not the purpose of the talk today. So in the VA, we have the opportunity to compare how dentists prescribe antibiotics to how medical clinicians prescribe antibiotics. So by medical clinicians, I'm aggregating physician prescribers, advanced nurse practitioners, and physician's assistants. And we were surprised to find that the proportion of all visits that received an antibiotic were similar between medical clinicians, shown in the gray bar, and dentists, shown in the blue bar. So for medical clinicians, about 18% of all visits were associated with an antibiotic within 7 days. And for dentists, it was just a little bit less at 16%. We also found that the antibiotic median day supply was similar for both groups. It was actually the same at 7 days exactly. And even if you look at the mean antibiotic days supply, they were also very close. They were both just shy of 8 days, a mean of 8 days supply for antibiotics. However, we found that dentists actually had higher antibiotic prescribing rates when we use a visit-based rate. And we also found that the prescribing rate was quite a bit higher when compared to medical clinicians. We also found that VA facilities with the highest prescribing dentists were at different facilities than the highest prescribing medical clinicians. Again, this is an issue because operations may be targeting antibiotic stewardship efforts based on those facilities with the highest prescribing rates. So Dr. Newhauser this morning described some antibiotic stewardship efforts that were implemented in the Department of Veterans Affairs, where a mandatory policy for the implementation of antibiotic stewardship was implemented in 2014. So we have seen the significant stewardship efforts across the VA, first starting in acute care and also going into outpatient medical care. We have not really seen many stewardship efforts in dentistry, but we're hoping that that will change. So over this time period, we found a greater decrease, a 7% decrease by medical clinicians. And we saw a decrease for medical clinicians across all prescribing groups. For VA dentists, we only saw a 1% decrease. But again, there's been few stewardship efforts specifically focused on dentists. However, one area for opportunity is we actually found a 4% increase in antibiotic prescribing by specialty dentists. Specialty dentists are considered endodontists, oral surgeons, prosthodontists, and those groups. So dentists prescribe differently, and it's important to note these differences between these groups when we try to adapt antibiotic stewardship to dentists and dental clinics. So dentists primarily prescribe agents in the penicillin class and prescribe very few broad-spectrum antibiotics. Less than 5% of all antibiotics prescribed by dentists are considered to be broad-spectrum, but about half of all antibiotics prescribed by medical clinicians are considered to be broad-spectrum. However, dentists are the primary prescriber of clindamycin in the United States. And of course, this is concerning because historically, clindamycin has been associated with the highest risk of C. difficile infection. Dentists also prescribe more antibiotics to prevent an infection and to prevent complications post-procedure. And we'll describe these reasons further in the talk. And dentists are also uniquely pressured to prescribe antibiotics not only by their patients, but also by medical clinicians. So dentists primarily prescribe only 2 antibiotics, amoxicillin overwhelmingly at about 60 to 70% of all antibiotics, followed by clindamycin at about 15 to 20% of all antibiotics. As I previously mentioned, the median day supply of antibiotic prescriptions prescribed by dentists is at 7 days. However, about a quarter of all antibiotics prescribed by dentists are greater than or equal to a 10-day supply, which seems surprising since the majority of antibiotics prescribed by dentists are for preventative reasons. typically prescribed as one dose prior to the procedure. So dentists prescribe antibiotics for the treatment of oral infections, as well as to prevent distant site infections, such as preventing infective endocarditis and for preventing prosthetic joint infections. Dentists also prescribe antibiotics to prevent post-procedural complications, such as an oral infection post-procedure, such as at an extraction site, or to prevent an implant failure or dry socket. Using VA data, we estimate that about 85% of all antibiotics prescribed by dentists are for preventative reasons. Now, of note, guidelines have narrowed indications for antibiotic prophylaxis, as well as the treatment of oral infections. But we've continued to see in the private sector an increase in dental antibiotic prescribing. So I know that there are some dentists in the room who probably feel like I'm picking on them quite a bit today. And I'll talk a little bit about what's been found in primary care medical clinics. But I want to note that there's been multiple studies to assess antibiotic prescribing by medical clinicians. There are hundreds, if not thousands, and there's been very few in dentists. So we have focused our analyses in 3 groups, and I'll present these results to you today in this order. So first, we'll talk about prophylaxis for distant site infections. Then I'll talk about antibiotic prescribing for prophylaxis for post-procedural complications. And then I'll talk about antibiotic prescribing for the treatment of oral infections. So first, distant site infections. So the next speaker will go into these guidelines in depth, but there are guidelines published jointly by the American Heart Association and the American Dental Association recommending 1 dose of an antibiotic prior to dental visits in patients meeting 2 criteria. First, that the dental visit involve a dental procedure that manipulates the gingiva or perforates the oral mucosa. And second, that the patient have a cardiac condition where if they do get infective endocarditis, they're at a high risk of an adverse outcome. And when these 2 criteria are met, antibiotic prophylaxis is recommended per guidelines. And of note, antibiotics are no longer recommended prior to dental visits in patients with prosthetic joints. We found that 91% of dental visits where an antibiotic was prescribed had that gingival manipulation criteria, but only 20% of patients had one of those cardiac conditions. Therefore, 80% of antibiotics prescribed prior to dental visits were unnecessary or prescribed outside of clinical treatment guidelines. Women, the Western United States, urban areas, and patients with prosthetic joints were predictors for unnecessary prescribing. However, I do want to note that we did see some improvement over time. And we've recently replicated this analysis. The results are not ready to share with you yet today, but we have seen a continued decrease in unnecessary antibiotic prescribing over time. So I also want to note that dentists overprescribe antibiotics, but so do medical clinicians. So I'm just highlighting 2 papers today, but again, there's hundreds of papers that describe this phenomena. And the CDC reported a few years ago that 1 in 3 antibiotics prescribed in primary medical clinics are unnecessary. And of those, over half of antibiotics were inappropriately selected in 3 respiratory tract infections where an antibiotic is sometimes indicated. Now, what primarily happened here was that the antibiotic that was selected was broader spectrum than treatment guidelines indicate. And when looking at specific indications consistently in the literature for a respiratory tract infection called acute bronchitis, which is viral in nature and does not require treatment with an antibiotic. Greater than 70% of visits where acute bronchitis is diagnosed received an antibiotic. So basically, these results that I'm sharing with you for dentists are not that surprising when you put it in context of the overall literature looking at antibiotic overprescribing. So next, we'll talk about prophylaxis for post-procedural complications. Now, I do want to note here that there are no guidelines, but there's been some evidence published by the Cochrane collaboration. So these papers are available free to anyone online. They're in the public domain. And this meta-analysis, again, conducted by Cochrane, compared the effectiveness of antibiotic prophylaxis on preventing oral infection and dry socket in persons undergoing tooth extractions. Now, most of the clinical trials that were included in this meta-analysis were done in healthy patients, or primarily healthy patients, who the majority of which were having their third molars extracted. And for the non-dentists in the audience, that means their wisdom teeth. And they found that 12 patients needed to be treated to prevent one oral infection, with higher NNTs for patients with impacted molars and for preventing dry socket. So there was no evidence in this Cochrane review that administering antibiotic as one dose pre-op or multiple doses post-op made any differences in preventing infection or dry socket. So overall, this Cochrane review concluded that the benefit of antibiotic prophylaxis in healthy patients undergoing extraction may not outweigh the risk of an antibiotic-associated adverse event. Another Cochrane study conducted a meta-analysis on the effectiveness of antibiotic prophylaxis on implant failure or for prevention of oral infections. So they found no difference in the frequency of oral infection based on whether or not the study subject received an antibiotic, but they did find a significant decrease in implant failure with an NNT of 25. And that is the risk ratio, the forest plot that's shown in this slide on the left. And these authors concluded that it might be sensible to suggest the use of a single dose of antibiotic prior to implant placement. However, a more recent review that was published in JADA, which is the Journal of the American Dental Association, added 2 additional studies to the review that was done by Cochrane. And they not only looked at the level of the patient in preventing oral infection and implant failure, but they also looked at the level of the implant, since patients may get multiple implants during one procedure. So this updated Cochrane review found a very similar NNT of 24 as the Cochrane review, and found an NNT of 43 at the level of the implant. So this updated review concluded that the results may not warrant antibiotics in healthy patients. So even though there's no guidelines, we found that it's very common practice to prescribe antibiotics prior to or pre and post-operative around extractions and implants. In the VA, in a small sample, we conducted a chart review of 400 visits with an extraction or an implant. We found that 85% received antibiotic prophylaxis. But what was surprising is that 70% received post-procedure antibiotics for 7 days, when only 1 dose pre-procedure was indicated based on the Cochrane collaboration reviews. We also found no difference in post-procedural infections in those that did and did not receive antibiotics, although our proportion of patients that had an infection was relatively small at about 3 to 4%. And as many of you know, veterans have many comorbidities and are considered to have complex chronic conditions. And we also did some stratified analyses by comorbidity, and we've still found no difference. So here, one thing that we identified with the VA sample is that antibiotic day supply or duration is a key area to focus on in stewardship efforts focused on dentists. So we are currently expanding this work as part of my VA Merit Award to conduct a comparative effectiveness project on the impact of post-procedural oral infections in veterans receiving extractions. And we've so far identified 386,000 dental visits with a tooth extraction. We are similarly conducting a separate analysis looking at dental implants, again in a veteran cohort. And here we have a cohort of about 49,000 dental visits where an implant was placed. Okay, so lastly, I'd like to talk about antibiotic prescribing for the treatment of oral infections. Now, I want to note that this analysis would be very difficult to conduct in the private sector or in your neighborhood dental clinic because few dentists in the private sector use ICD-9 or 10 codes. Dentists use something called comprehensive dental terminology, which you can consider to be dental procedural codes, but very few dentists actually use ICD-9 or 10 coding. But in the VA, all VA dentists use not only these dental procedure codes, but also use ICD coding. So we can more accurately associate a diagnosis with an antibiotic prescription. So the ADA guidelines, which were referenced by Malavika Tampi this morning and which will be further described in the next presentation, do stratify analyses by whether or not the patient has access to a dentist within 72 hours. So our cohort all had access to a dentist. So we only used one side of the treatment algorithm. And in that treatment algorithm, there's 3 oral infections that have recommendations on whether or not an antibiotic is recommended. So for irreversible pulpitis and apical periodontitis, an antibiotic is not recommended. And then for acute apical abscess, only when there's systemic involvement are antibiotics recommended. The other thing I'd like to note is that these guidelines were published in, I believe, late 2019, and we used data from dental visits in the VA from 2017. So this provides a baseline of guideline concordance prior to guideline release. The guidelines are also specifically focused on patients who are immunocompetent, but we included immunocompromised patients, but did account for immunocompromised patients in our sensitivity analyses. And our sensitivity analyses, by excluding immunocompromised patients, did not drastically alter our conclusions. So we found for irreversible pulpitis and apical periodontitis that the vast majority, over 80%, did not receive an antibiotic and thus were concordant with the guidelines prior to guideline release. And we were pleasantly surprised by these numbers. We rarely see this type of high guideline concordance in any type of infection, not to mention prior to a guideline even being released. We also did not assess whether or not antibiotics prescribed for acute apical abscesses were guideline concordant because systemic symptoms are relatively difficult to assess in administrative data. And while the VA corporate data warehouse does include the patient's temperature and we could assess for fever, we cannot assess for other types of symptoms such as lymphadenopathy. So we chose not to do that. But we found that about 27% of all patients with acute apical abscesses received an antibiotic. And just for those of you who are not dentists in the audience, acute apical abscesses need dental treatment pretty much immediately because it can be a life-threatening infection. So from my perspective and based on the data, what can dentists do today? First of all, dentists can prescribe first-line antibiotics as recommended in the AHA and the ADA guidelines. And in other type of recommendations from specialty organizations, the majority have amoxicillin as the first-line antibiotic. Now, if the patient is penicillin allergic, they should consider cephalexin or azithromycin, which are the second-line agents now recommended in the new AHA guidelines on the prevention of infective endocarditis, which were just published this spring, as well as the ADA guidelines on the treatment of oral infections. The ADA guidelines also nicely lay out some options for dentists to question their patients to see if they can tolerate a beta-lactam, such as cephalexin. And the next speaker will also highlight this briefly. We would also like to see that dentists identify true penicillin allergies, asking patients, when did this happen? What was your reaction? And have you ever taken a beta-lactam antibiotic? Now, the issue of shorter courses of antibiotics did come up this morning, but the overall thought emerging in the infectious disease specialty is that shorter is better. And if you Google shorter is better, you'll get a paper will pop up by Dr. Brad Spellberg, which lays this out very nicely. So we do recommend shorter courses of antibiotics, which are also supported by guidelines. And we also recommend that dentists only prescribe antibiotics for each appointment that is needed for those patients that require prophylaxis, or for each set of appointments. So frequently in dentistry, visits are frequently connected. The need for an extraction is identified at one appointment, and the patient comes back in a week or two for an extraction and then may start the process of getting an implant. So that would be an example of a set of appointments. But please do not prescribe 10 days of antibiotics for patients who require prophylaxis. And what we're trying to avoid here is patients having antibiotics sitting around in their medicine cabinet and potentially taking those for other indications, such as a viral respiratory tract infection. We also want to recognize that dentists are the experts on indications for antibiotic prophylaxis. And we all need to educate medical clinicians on appropriate indications for antibiotic prophylaxis, especially that antibiotics are not required for prevention of prosthetic joint infections in patients with orthopedic implants. And then in another body of work that we're currently undergoing, we found that treatment of a toothache or oral pain is something that medical clinicians truly struggle with. And in the ADA presentation this morning, you could see that they are partnering with emergency medicine professional organizations to include them on guideline panels, as well as policy in general, to support medical clinicians on appropriate management of toothache and oral pain. And we would love to see dentists be a resource for medical clinicians in this space. And we know we have some room for improvement in the United States because the US has the highest antibiotic prescribing rate when compared to dentists in Australia, England, and Canada. And even though these 4 countries have different healthcare systems, the oral health and use of the dentist is very similar between these countries. So why do we see such significant differences in prescription rates between these countries? Well, one big reason is that our treatment guidelines differ. In England and in Australia, antibiotic prophylaxis is rare. Only a few patients with cardiac conditions receive prophylaxis. In addition, antibiotic prophylaxis is not used routinely in patients getting extractions or implants. And in Australia and in England, dentists have never recommended antibiotic prophylaxis in patients with prosthetic joints, and that's never been part of their treatment guidelines. However, Canada and the US have similar guidelines, and there's broader recommendations as well as a common practice to prescribe antibiotic prophylaxis, not only for preventing distant site infections, but also post-procedural to prevent post-procedural complications. So when we talk about improving antibiotic prescribing, we also need to recognize that there's similar and unique factors to antibiotic prescribing when we compare medical clinicians to dentists. And since the majority of antibiotic stewardship strategies have been implemented in medicine and designed for that group, we need to be cognizant of this when we tailor antibiotic stewardship to dentists. So those factors for medical clinicians are listed on the left. And those that are similar to dentists, which are listed to the right, are patient influence in prescribing an antibiotic, patient access to care, and that also includes oral health care, the patient-provider relationship, and then the factors differ. So for dentists, factors that lead to increased antibiotic prescribing includes lack of access to guidelines, as well as data to inform their prescribing decisions. Dentists also may not be able to conduct a procedure because there may be overwhelming oral swelling, and the patient needs some time before they can come back and actually have the dental procedure done. The dentist's perception of their skills in delivering dental treatment, meaning an extraction or a root canal, especially during emergency calls when a patient is emergently presenting to the dentist, as well as competing demands. And this competing demands it's interesting to me that this only showed up in dentistry, because I would think that this happens in all healthcare settings. But in dentistry, you have patients presenting with significant pain, and the dentist needing to do dental treatment, so a procedure, but still being able to see their patients that are sitting in the waiting room with scheduled appointments in a timely manner. So in these situations with competing demands, dentists do feel pressure to prescribe an antibiotic and have the patient come back for the dental procedure. So I think that this is a very interesting time within antibiotic stewardship and linking what we know about stewardship to dentistry. And it's optimal because there's so many different opportunities now to start the conversation. There are several policy statements that were nicely reviewed this morning that all recommend the implementation of antibiotic stewardship, including incorporating stewardship in the dental curricula, as well as into dental professional education, as well as for hygienists. And just a plug that the American Dental Education Association specifically highlighted what you'll hear about in the last session with the antibiotic stewardship implementation at UIC. And it's also important to have shared decision-making, starting the conversation with our patients, that antibiotics are not always indicated where maybe they were before because of changing guidelines. And this is a trifold brochure that's available for free on the CDC website that can be printed out and distributed to your patients and be used as a tool as you talk to patients about when antibiotics are and are not indicated. So if you are interested in implementing stewardship in dentistry, there are several resources available for free. I want to note that when I initially approached UIC about implementing stewardship, I used the Illinois Antibiotic Stewardship Toolkit, which is customized to dental providers. But there's also a toolkit available from the state of Massachusetts. And then there's also posters that can be customized to a dentist by inserting their picture, or a dental practice where you can insert a logo from Michigan and Minnesota. And then there's also several tools available from the CDC that are customized for dentists. I also want to provide these links to you, which I'll put in the chat, which are specific antimicrobial stewardship training. The first train.org was highlighted by Dr. Newhauser this morning, and there is a specific module targeted to dentists. And then the British Society of Antimicrobial Chemotherapy also put a MOOC, a massive online open course, together that is also customized to dentists on tackling antibiotic resistance. So I'd like to acknowledge my collaborators on the work that I presented today, especially my collaborators at UIC, Dr. Gross and Dr. Rowan and Dr. Hanna, and then my partners, the American Dental Association, the Illinois Department of Health, and the VA Antimicrobial Stewardship Task Force and the Office of Dentistry for their support in these projects. And I can now take any questions that you may have. So I will exit my presentation and look at the chat. Oops. I apologize, I might be making you. Okay, I don't see any questions. I don't know if any of the other speakers are on and want to make a comment about their presentations and what they'll be talking about today. Okay, well, thank you all so much for your attention, and I hope you enjoy the rest of the Stewardship Summit. And my email address is here if there's anything that, any additional questions. And like I said, I'll put these two links in the chat box for your reference. Enjoy the rest of the summit.
Thank you, Dr. Suda. That was really informative and interesting, and we really appreciate your time.
Thanks, Hiba. Thanks so much for your help today.
Yeah, of course. Thanks, everyone.